Hello, welcome to Chronic Illness. This content follows on from my last video on restless leg syndrome medications. If you haven't already, please go back and watch my earlier videos in order so you understand the topic properly. They're linked below. If you've already watched them, fantastic. In this video, I'll explain the non-medication-y things you need to do to address your RLS, as well as some do's and don'ts when taking medications. I'll also talk you through the medications and strategies recommended to treat the different categories of RLS. First, I gotta give you that disclaimer. Now, I know long intros and disclaimers are boring, but because I'm talking about medications, it's very important that I include a proper one here. Okay, these videos are not medical advice. I am not telling you how you should treat your RLS. That's between you and your doctor. I have a biology degree, but I am not a doctor. I'm just someone who is good at research and has a platform on the internet. All I'm doing here is reading and summarizing the scientific literature written by the experts in the field and translating it to you via these videos. I'm just the messenger. This is not advice from me personally, it's what's advised in the scientific articles. My goal is for you to be aware of the various medications available and their pros and cons. You should also know that this is all general information. Not all of these options will work for all people. We all have genetic differences and different medical histories and needs, so a medication that works for others may not work for you and vice versa. You have to tailor your treatment to your individual needs. Here are some things you need to do to improve your restless leg syndrome besides taking medications. I'm not going to go over all the possible treatments because I did that in my first video, so check that out if you're interested, especially in alternative treatments and all the little hacks that I've picked up over the years. You'll generally be expected to try the non-medication things before or in conjunction with any pharmaceutical meds. If you can manage your RLS without meds, that's ideal, but even if your RLS requires medication, doing the home remedies and non-medical stuff can reduce the dose you need, which reduces side effects and the chances of augmentation. 1. Check iron and bolster iron levels if they're low. Super important in any case of RLS. Check that B12 too and get it up to speed. 2. Exercise. Study after study after study has shown that mild to moderate aerobic exercise with some resistance improves RLS. So if you are well enough to exercise, you really need to be doing that. Keep it moderate, as both a lack of exercise and overly intense exercise can exacerbate your symptoms. See my first RLS video for more detail about the sort of exercise that benefits RLS. 3. Eliminate or reduce substances that can worsen RLS. I mentioned this in my first video, but I want to go into more detail. Caffeine, alcohol, and nicotine can make RLS worse, so cut down on those or cut them out entirely if you can. I'm not going to cut my coffee out entirely, but I do try to keep it to a minimum. But yeah, I'm not ready to give up my coffee in the morning, no way. Melatonin. Melatonin is a hormone that your body naturally produces in the evening to make you sleepy and to signal to your body that it's time to sleep. Many people with insomnia take melatonin at night to help them fall asleep, but for some people, melatonin actually kicks off their RLS. This is because RLS is very much driven by circadian rhythms, and the melatonin can signal to your body that it's time for the RLS to kick in. So it's not so much that melatonin causes RLS, but it can trigger the timing of it. But it won't do this for everyone. I do take melatonin and I don't find it triggers my RLS. It helps me to get to sleep. So just know that it can go either way. If you find melatonin helps you sleep, there's no need to stop taking it. But if you find it makes your RLS worse, it's best to cut it out. You may need to taper off it slowly, as if your body is used to receiving melatonin orally, it can take a bit of time for your natural production to kick back in. Some medications can worsen RLS. Remember that RLS is a dopamine transmission problem, so dopaminergic meds, or those that affect the dopamine systems in your body, can exacerbate the problem. These are mostly the psychotropic meds, so the antidepressants and the neuroleptics, also known as antipsychotics. Oh, my voice is gravelly today. I can't get those low notes. It's cracking. Why? Why? The day I'm filming. I don't know. All right. Remember I said that too much dopamine causes hallucinations and psychosis. So neuroleptics work by blocking dopamine receptors in the nervous system, particularly the D2 receptors, so the opposite of what we want for RLS. I won't mention all of them, but some common neuroleptics are clozapine, olanzapine, risperidone, and chlorpromazine or largactil, the latter of which I'm on. I don't have psychosis, but I was prescribed it to help with some of my ADHD symptoms and to help with sleep. And I've not found that it worsened my RLS, so don't despair because it won't necessarily have that effect for you. Just be aware that it is a possibility. As for antidepressants, almost all of them can worsen RLS since most affect dopamine transmission. The SSRIs and tricyclics are known culprits, but the SNRIs can do it too. Some common SSRIs or selective serotonin reuptake inhibitors are sertraline or Zoloft, which I'm on, citalopram or Celexa, escitalopram, Lexapro, and fluoxetine, Prozac. Some common tricyclics are imipramine, clomipramine, mirtazapine, amitriptyline or Endep, and nortriptyline or Allegra. I've been on the last two. I'll talk about them later. Common SNRIs or serotonin norepinephrine reuptake inhibitors include duloxetine, venlafaxine, and desvenlafaxine. As you can imagine, depression has a big overlap with RLS, but there is one antidepressant that doesn't exacerbate RLS, and it's called bupropion or Wellbutrin. So if you suspect your antidepressant is affecting your RLS, but going off antidepressants isn't an option, you might want to consider switching to bupropion. Lastly, the sedating antihistamines can worsen RLS, as can the dopamine-blocking antiemetics. That's meds to stop nausea and vomiting, like metoclopramide. So if you're using these for nausea, allergies, or as sedatives to help you sleep, be aware that they could be worsening your RLS. Other things that worsen RLS are conditions that cause hypoxia or low oxygen, including sleep apnea and chronic obstructive pulmonary disease. Blood loss can also cause RLS, so get any of these conditions treated. Another thing that worsens RLS is, get this, insomnia. Yes, insomnia itself worsens RLS. And RLS worsens insomnia. So you get this vicious cycle developing. And not only does insomnia worsen RLS, it also worsens augmentation. So you need to do everything you can to work on your sleep. There are a lot of things you can do, like sleep hygiene, blue blockers, meditation. Keeping a diary of your RLS symptoms and sleep habits can help you pick up patterns. I won't go into sleep management here, but just know that you will be expected to address these things as part of your treatment for restless leg syndrome, and they can really help with managing your RLS and improving your sleep. I've made a short video on ways to trigger your body to sleep. I'll link it below. This section will go over general things to consider when taking RLS medications. The two major challenges in treating RLS are augmentation and loss of medication efficacy over time. For some reason, RLS meds can become ineffective over the long term, so years to decades. This is different to augmentation because the RLS isn't getting more severe, it's just going back to the way it was before you started the meds. The way you deal with this is to switch up the type of meds you're using. You may switch to a longer acting drug, you may switch to a different class, say from a dopamine agonist to an alpha-2 delta or an opioid. You may add in a new drug but keep the existing one going, perhaps at a lower dose. So you've got some options there, which I'll go into when I talk about the different categories of RLS and their treatments. The first principle is to keep the dose of any dopaminergic medicine as low as possible. Start low and titrate up to the effective dose slowly. Never go above the maximum recommended dosage for RLS, especially for the dopaminergic medications. As I said earlier, even some doctors don't know about augmentation, so they may try to prescribe you higher doses. That said, treatment with A2Ds can fail due to inadequate doses. You have to keep titrating up slowly until you get the beneficial effects, and then you don't want to go above that level if possible. Even though the A2Ds don't cause augmentation, it's still a good idea to keep the dose at the lowest effective level because that just minimizes the side effects that you're going to get if you get any, and it also gives you some wiggle room, like if you do need to increase the dosage later, you've got some scope to do that too. The timing of when you take your dose is very important. In fact, sometimes you can see improvement just by adjusting when you take your meds without increasing the total dose. RLS follows circadian rhythms. You want to learn when your RLS usually comes on and take your meds 1 to 2 hours before that time. This is because it's more effective to prevent the restlessness coming on in the first place than it is to let it set in and then try to get it under control. Splitting the dose up instead of taking it just once a day can help you reach ideal blood levels at the right time, especially with gabapentin, which is processed by the body in a non-linear way. Correct timing and split dosing are especially useful for short-acting RLS meds to make sure they don't wear off too soon. Your specialist can fine-tune these things for you. Alright, 3. Monitor your RLS regularly and watch for signs of augmentation or return of symptoms. Augmentation manifests as the RLS increasing in severity, starting earlier in the day or spreading to other parts of your body. If your meds haven't been working as well and you've gradually been increasing the dose, this is a red flag for augmentation and you'll need to switch tactics. 4. Consider other medical conditions when choosing your medication and tailor your treatment plan to your individual needs. Many of the papers I read stress a holistic approach tailored to the individual. Many of the medications used to treat RLS also treat other conditions. If you pick a drug that treats multiple issues, you can kill 2 birds with 1 stone. 5. Consider side effects and medication interactions. Any good doctor will inform you of potential side effects, at least the most likely ones or serious ones, and they will consider any risk factors before prescribing you a medication. You may have certain risk factors or underlying medical conditions that will make some RLS drugs unsuitable for you, so make sure your doctor is aware of your medical history. Managing side effects. Now, side effects suck, and they can be really scary when you see them all written down when you start a new medication, but don't assume the worst because they don't happen to everybody. We all have genetic differences in the way we process medications. You might not experience side effects, or you might only experience them temporarily, as some side effects are just initial and wear off in the first few days or weeks. Or you might get side effects, but they're mild enough not to bother you too much, or that you can manage them with other approaches. You have to weigh them against your RLS. If you've watched my videos this far, your RLS is probably pretty bad. It might be worth putting up with some side effects if you get relief from your RLS to the point where your quality of life is significantly improved. Also know that the interactions between different medications can cause side effects that the individual medications would not produce on their own, or they might magnify the usual side effects beyond the simple addition of symptoms, so the whole is more than the sum of its parts. Let's say you're already on medication A for something, and you start medication B for your RLS. Then you get some nasty side effects that your doctor suspects might be due to an interaction. Instead of dropping drug B, you might want to reduce drug A if it's safe and see if that helps. You could also replace drug A with a different drug that treats the same condition. So you switch to drugs B and C, and you might find that combo suits you better. Also consider that side effects are usually dose dependent. The more you take, the more pronounced the side effects generally, which is another reason to take the lowest effective dose. Not only that, but sometimes side effects are non-linear. They only kick in when you hit a certain dose, and if you can stay under that threshold dose, you might be able to avoid that side effect altogether. For example, one of my medications, not for RLS, a different one, it causes night sweats, but only at doses above 100 milligrams. If I take 100 milligrams or below, I don't get night sweats. But as soon as I go above that, the night sweats kick in. So I have to keep that one at 100 milligrams, even though I could use the extra effect from it, just not badly enough to put up with the night sweats, which were really disrupting my sleep. So it's a compromise. Knowing that, you might use a combination of RLS meds in low doses. Let's say medication X alone controls your symptoms at 100 milligrams, but gives you side effects. Let's say that medication Y alone also controls your symptoms at 100 milligrams, but produces side effects. At 50 milligrams, neither of these meds alone cause side effects, but nor do they control your symptoms. But if you take both X and Y at 50 milligrams each, you might get symptom relief while avoiding the side effects. These are made up numbers, by the way, just to illustrate the point. These things can be complicated and involve a bit of trial and error, but it's worth fine-tuning your medications to get the best outcome. Your specialist can advise you on this process. 6. Don't expect total relief. The experts who wrote these papers caution patients and treating doctors not to aim for or expect total cessation of symptoms. For a small subset of patients, complete and permanent relief may be possible, but this is usually when the RLS is being caused by something else and you eliminate that thing. So if you've got RLS because you're iron deficient and you correct that, the RLS may go away completely. Same with if it's being caused by a medication and you discontinue it, or if the RLS is due to pregnancy, it can go away after you have the baby. But for most people, complete and permanent recovery is not realistic. But that doesn't mean you'll always struggle with it. RLS can be treated to the point where you've got quality of life again and you're sleeping well at night. Your symptoms may be there, but they're minimal and manageable. So don't lose hope, just don't expect a miracle. We don't have a cure. Yet. One last thing, finding a good doctor can make all the difference. Don't just go to the first person available if possible. It's worth hunting down a good doctor, one who is knowledgeable, experienced, competent, and compassionate. There are many kind, dedicated doctors out there, but there are also some real a-holes. Some doctors have a big ego and they don't listen to a word you say. Others are stuck in the past and continue to recommend outdated treatments. You don't want to see them if you can help it. Now, I know some people don't have many options available, but if you do, try to choose a good one. It can help to join a Facebook group or forum based in your location, where people discuss their experiences with doctors. You'll hear who the good ones are and who to avoid. Other signs of a good doctor are that they have won awards for their work and that they're members of medical organisations that require their members to maintain high standards. I'll deal with finding a good doctor in more detail in another video. One last thing, you can email or print out journal articles to give to your GP to read. A GP is a general practitioner or a primary care physician if you're in the US. Doctors are usually overworked, and even the good ones might not have time to read the latest research. A specialist in RLS should be up to date with their knowledge of the condition, but if your RLS is being managed by a GP, they might appreciate you bringing a printout of a relevant journal article or emailing it to them. Be respectful about it. Don't try to lecture them. They are the experts. Don't just be like, oh, I found this thing on Google, now you have to do it. Yeah, don't do that. Just bring the printout and offer it to them. I suggest the article Silber et al. 2021, linked below. It's actually a treatment summary made for primary care physicians to use with their patients, and it's free to access. It's actually one of the more readable ones, so you might even like to read that yourself. In this section, I'm going to outline the current treatment guidelines for restless leg syndrome. Just a reminder, this is not medical advice. I'm just summarising what's suggested in the medical journals so you know what your options are for treatment. You'll need to work with your doctor to develop a treatment plan that suits your individual needs. I'll add this is general information that applies to adults, not children, and those who are not pregnant. I've decided not to deal with the treatment of RLS in childhood or pregnancy since I don't feel comfortable dealing with those special categories. I will say RLS at these life stages can be treated. You've got some good options for RLS medications that are safe to use during pregnancy and lactation, and some that are safe for kids, but you'll have to talk to your doctor about that. I'm also not going to deal specifically with RLS caused by renal insufficiency and other specific diseases. The following recommendations apply to RLS in a general sense. I won't give you specific doses because they can vary greatly between individuals and your doctor will be able to advise you. There's also dosing info in some of the articles linked below if you're curious. Okay, so there are roughly 3 categories your RLS can fall into. The first is intermittent RLS, the second is chronic persistent RLS, and the third is refractory or augmented RLS. The flowchart diagrams come from Silber et al. 2021. I've done my best to make the diagrams clear on this video, but if they're hard to make out, you can see them in the original paper linked below. It's free to access. In intermittent RLS, the restless symptoms are infrequent. They are bad enough to require treatment, but only occur sporadically, or once or twice a week or less. So maybe you just get it flaring up on a random night, or maybe you only need medication in specific circumstances, like a long-haul flight or a long car trip. If that's you, I've got good news. Your RLS can generally be treated with medication successfully long-term, and you may be able to get away with using the good meds, like levodopa, as long as you're not taking them too often. It's taking them frequently and regularly that tends to cause augmentation, but if you just take them every now and then, it shouldn't develop. Here's a summary of treatment for intermittent RLS. First, you try all the non-medication strategies. You also need to check iron levels and get them up if necessary. If the symptoms are still problematic, you can be prescribed on-demand medications. These are things you only take occasionally. They're not suitable to be taken daily. These are levodopa, benzodiazepines, or low-potency opioids. Now, if you start needing to take these more and more nights per week, it means that either your RLS is increasing in severity or augmentation is occurring. If that's the case, you need to switch to medications designed for chronic RLS. Chronic persistent RLS. Silber et al. 2021 defines chronic persistent RLS as restless leg symptoms that are frequent and troublesome enough to require daily treatment, usually occurring on average at least twice a week and resulting in moderate to severe distress. So the RLS is chronic, meaning long-term, and persistent, meaning it's frequent and not going away on its own. This will be a lot of you watching right now. You'll have RLS symptoms severe enough to cause distress and insomnia, occurring 3 to 7 nights per week. This requires a long-term treatment plan. We're talking years to decades. Here's the treatment flowchart. First, of course, you do all the non-pharmacological stuff and you check the iron and treat any deficiency. Then the first choice of medications are the alpha-2 deltas, gabapentin, pregabalin, or gabapentin in carbol. You would take these on a daily basis in 1 or 2 doses an hour or 2 before bedtime or before the usual onset of symptoms. If for some reason A2Ds are not suitable for you, you would then consider the dopamine agonists like pramipexole, ropinirole, or rotigotine, taking the lowest dose necessary and monitoring for signs of augmentation. Splitting the dose in 2 or switching to a longer acting drug are also ways to better manage the symptoms without increasing your total dose. But what do you do when you can't take A2Ds or DAs? In that case, your RLS would be considered refractory and treated as follows. Refractory and augmented RLS. Now, what are these? Augmented RLS is pretty straightforward. This is just RLS that has been made worse by augmentation due to dopaminergic therapy. So you've been taking the dopaminergic meds for a while and they've made your condition even worse, and upping the dose is not an option. Silber et al. 2018 write that refractory RLS is characterized by unresponsiveness to dopamine agonists or alpha-2 deltas due to inadequate efficacy, augmentation, or adverse effects. So refractory refers to RLS that is treatment resistant. In particular, it's resistant to treatment with a single medication or monotherapy. There are a few reasons this can occur. Perhaps you have underlying medical conditions that make A2Ds or DAs too risky or potentially dangerous for you to take. Or you may have tried them but found that the side effects were too severe to tolerate. Or you may have taken them and they worked for a while, but now you're finding they're becoming ineffective against your RLS. Your symptoms are breaking through, or perhaps they're even being augmented by the medication. Don't despair, we have some options. Let's start with the flowchart. As always, aggressively pursuing non-pharmacological strategies is a must, as is addressing low iron. As I said, low iron will worsen augmentation. It can also cause previously effective medications to stop working, so it is crucial to get your iron up if it's low. Oral supplements may not be enough. You'll probably need an iron infusion. See my section on iron for more details. Silber et al. 2021 write, if the serum ferritin level is less than 100 micrograms per litre and symptoms are severe, intravenous iron therapy should be considered. Next, consider combination therapy with different classes of drugs. For those who can tolerate DAs and A2Ds, combining them can treat the RLS more effectively than one of them alone. You can also consider adding other drugs like a benzo. When those things aren't possible, it's time to use an opioid. Opioids are highly effective in relieving RLS symptoms. The most widely recommended option is low-dose methadone, but an oxycodone-naloxone combo can also work, and there are others. By the way, if you haven't already, you must go back and watch my section on opioids in the previous video because it's very important information to consider. Now, the choice of opioid depends on the timing of your symptoms. If symptoms are only present 4-ish hours a day, you could use a short-acting one like oxycodone. But it's more likely your symptoms are present 6 to 10 hours a day or more, in which case a long-acting opioid like methadone or buprenorphine is preferred. For both refractory and augmented RLS, the main aim is to switch out the drug that isn't working for a better one. So if you're on a DA and your RLS is augmented, you want to switch the DA to an A2D or an opioid. If you can't take A2Ds or DAs or they're not working, you want to switch to an opioid. Now, the way you switch over is very important. It has to be done very carefully and strategically. In most cases, the opioid or new medication should be added in before you go off your current RLS meds. This is because even small dose reductions, particularly of the dopamine agonists, will cause profound rebound RLS and insomnia. The symptoms can be unbearable and you may not sleep for a week or two if you try to go off the DA without something else as backup. 2 weeks without sleep is very dangerous and can do tremendous damage to your body and mind. So you want to titrate up with the new drug, then once an adequate dose is reached and you're getting symptom relief, you very slowly down titrate and discontinue the DA. So your existing medications here, we want to go up with the new one, then down with the old one. Or you might even do them both at the same time. So you might go up until you get some symptom relief at the same time as you're gradually going down with the old one. However, in some cases you might need to stay on the DA, but keep the dose very low so you don't eliminate it completely. The combination of the opioid and the low dose of the DA may provide the symptom relief you need without the dose escalation that generates augmentation. Be aware that your RLS will likely worsen for 3 to 7 days after every DA dose reduction. Just remind yourself that this is temporary and you're on the path to long-term relief. Don't be too ambitious about coming off the DA. It can take 3 to 12 months to taper off safely. And don't let your doctor push you into titrating too aggressively. Something I have found in my decades of experience with medications is that doctors consistently underestimate how much time is needed to taper off a medication and how brutal the withdrawal symptoms are. So take your time. You also need to tweak the rate of titration of both the meds depending on symptoms. You usually need to taper down the DA more slowly as you go along. This is because if you taper off linearly, the percentage reduction is higher the further along you are. To explain what I mean, I'm going to use some made up numbers. These are not the doses you'd be working with, they're just to illustrate the point. So say you are on 100 milligrams of a DA and you reduce it by 10 milligrams. That's a 10% reduction. Now say you're down to 20 milligrams of the drug and you reduce it by 10 milligrams. That's a 50% reduction, which your body might not be happy about. So just go slow and know that it will probably take a bit of trial and error to get it right. It might be a 2 steps forward, 1 step back sort of situation, but keep going because the end result will be substantial improvement in your condition. That ends the content on treatment of restless leg syndrome. I hope it's been helpful. The final video in this series is about my personal experience with RLS medications. If you're interested, please subscribe to my channel so you don't miss out. And please, pretty please, give me a like or a comment or a share or something because I put a lot of work into this video, so I'd really appreciate it. Okay, I'm gonna go now. Bye. I think someone's using a leaf blower. Why? Why now? Dude, just enjoy your weekend. Why are you working? Well, because they don't have time to work in the weekday, do they? Because they're working, slaving away for our capitalist overlords.